I don't understand anything because I'm surgeon, but I believe that it's something that physiotherapists understand. But anyway, we got the point that and we know that probably the AC joint is quite underestimated. It's an AC joint, no problem. You can go back when you want. No, I mean the message is to say that they have to be prepared, they have to be treated and rehabilitated correctly. We are short of time, so if you have some discussion, it will be some questions. It will be at the end. I will try to take 5 minutes to finish, and believe me, I will shorten the presentation because it's already the coffee break. So my purpose is to give you a brief message about the surgery and why I did put this picture. It was because my thesis was about the acromioclavicular joint, about special surgery, which is the name is Dewar-Barrington procedure. And to be honest, I did the study in the department where I was a fellow, and then I didn't do any more of this kind of surgery, which was for me very difficult for the patient. And in addition, I become during the following years, a clear defender of the Latarjet procedure. So imagine when you use this coracoid process to stabilize the clavicle, if you have a shoulder instability, then you're not in the best position. But it illustrates something. It illustrates that for AC joint dislocation, you believe me, it's incredible the number of different surgical procedures that have been developed, proposed, and used by the surgeon. What does it mean? It means no one surgery is much better than the other, if we can conclude. But we can say that the outcomes after surgery reconstruction are good. And you know that from your experience. But we can say on the same time that the majority of the patients do well with non-surgical management. So how do we do? I mean, do we have to operate them again? Do we have to treat them conservatively? Again, the same question. Probably it's a case-by-case management. And if we come back to the Rockwood classification, it's clear that probably for the majority of us, there is a consensus to say that the conservative treatment is okay for grade 1 or grade 2. I'm talking about acute. Probably sometimes there are some residual pain for even after conservative treatment. In this case, we can do surgery, but not in the first stage. Surgery for this big deformation is obviously the best technique. But for the grade 3, the one we can see very frequently, what can we do? What do we do? And what must we do? It is still controversial. And this is very interesting because it's not a scientific study, but it's very interesting to know, to listen this kind of thing. The American Orthopedic Society surgeon, they did a survey in 2007. They conclude that 81% of the surgeons in 2007 recommend conservative treatment for type 3 Rockwood. So it means I'm surgeon, okay, I'm part of this guy, say no. Don't do surgery for grade 2 because you know it works very well if it is if you have a conservative treatment. And imagine that in 1974, only 9% recommend the conservative treatment. So it means 91% recommended surgery, and now only 19. So it means the things move, change, and this is not evident, but I call that experience. And again, if surgeons don't recommend the surgery, it means in their experience they are not so happy and they know that they can manage this group. It is still controversial. And this is very interesting because it's not a scientific study, but it's very interesting to know, to listen this kind of thing. The American Orthopedic Society surgeon, they did a survey in 2007. They conclude that 81% of the surgeons in 2007 recommend conservative treatment for type 3 Rockwood. So it means I'm surgeon, okay, I'm part of this guy, say no, don't do surgery for grade 2 because you know it works very well if it is if you have a conservative treatment. And imagine that in 1974, only 9% recommend the conservative treatment. So it means 91% recommended surgery, and now only 19. So it means the things move, change, and this is not evident, but I call that experience. And again, if surgeons don't recommend the surgery. It means in their experience they are not so happy, and they know that they can manage these are more important than the acromioclavicular ligament. And some people use gracilis, for example, to restore, they harvest gracilis to restore the ligament. That is for this reason that some surgeons said, during this last year we have seen a lot of progress in shoulder surgery, but in the same time more people limping after the surgery if you harvest some tendon on the knee. But anyway, it's an anatomical surgery that you can do arthroscopically. It's quite nice. It's you restore, you really reconstruct. This is what we like. And you know that some people during the last 10 years have advocated and pushed to do this kind of surgery, which is under button, which is a flexible system that allow you to restore the stability between the clavicle and the coracoid process. After a period of enthusiasm, and I was part of this, and I'm sure you were part of this, and don't forget that it's a sort of buzzwords, and that this time we had 32% of failure. In the experience, after a few years, we realized that it's not so easy. First of all, technically, it's under arthroscopy, but technically it's not so easy. If you look at the picture, you say, what is this surgeon? You put that like that. No, honestly, it can slide. It can be difficult because it's very difficult to put on the right side. You can have a coracoid fracture, even if you do correctly the surgery. And this is one of my patients. I was not happy because I was happy initially with, not in this one. And the button was perfectly placed like in the technique with the system. And the system stretched progressively without any reason. And at the end, we lost the reduction, and believe me, the patient was not happy, even if the system was put in the book. So it means, again, so this is the afternoon to say that surgery is not perfect, but it's sure, especially for this kind of thing, there is no big surgery, best surgery over the others. So keep this message and make your decision based on this. But which surgery? Because if in the panel of surgery, we have to choose which one. Apparently, you know, the arthroscopic one is not so good as we could expect it, because I show you there's some complication. And by the way, I don't use anymore, and I came back to the Weaver-Dunn technique, which is a very good technique. But if you look at this very interesting study in 2013, they did a systematic review about all the technique. Imagine 162 different techniques for operative reconstruction of AC joint. It shows you that everybody is trying to find the right solution and not one. They show that there is a lack of evidence to support treatment options for patients with AC joint dislocation, and there is no way to say today that there is an evidence for a one better surgery or another in terms of early versus delayed surgical treatment or anatomic versus anatomy. In other words, we don't know if we have to operate them in an acute situation or if we can wait in chronic, because there is no difference. So for people, it's a good justification to say we can wait, and if it doesn't work, we can do that in chronic situation. And we don't know if the anatomical reconstruction that I will show you are better than non-anatomical. So anatomical is with a gracilis from the knee, and non-anatomical are like Weaver-Dunn. There is currently no difference in terms of stabilization. So it means we can use whatever technique we have in our hands, as long as you have experience and you are used to use this technique. So at the end, which technique? Probably we have to separate the acute and chronic technique, clinic case. In acute case, we have to make a decision, because we have to know, do we have to operate, or we can wait and put the patient in a conservative treatment. In chronic case, it's different. The patient comes, he's symptomatic. He had already the conservative treatment. He comes with pain, instability. Obviously, you have to propose him something. So there is no big deal and big difficulty to do the surgery for chronic case, because the patient is symptomatic. So you cannot live like that, except that if he had no good physiotherapy, as said Florence, if you identify that he didn't do correct physiotherapy, first you have to correct the muscle strengthening and the balance and the scapular balance, and then if it doesn't work, you do surgery. But this is a chronic case, for example, and there is no doubt that this guy has a real dislocation, grade 3, a few months after an ACL, an AC joint correctly rehabilitated in physiotherapy here. And he had this piano sign, this anterior-posterior draw test. So how can we, I mean, for us, surgeon, it seems obvious. in a chronic situation, how can we hope to stabilize only with muscle recovery if the patient had already physiotherapy? So for this kind of patient, obviously you have to stabilize them, and not only to fix, but to reconstruct the coracoclavicular ligament. So it will be my final slide. This is the proposition of our proposition for the sort of algorithm of decision for the AC joint dislocation. If you have a type 1 and 2, clearly you do a conservative treatment, and if after a few months there is still pain, you can always do surgical treatment, it's not a big deal. If you have type 4, 5, 6, or symptomatic chronic AC joint, correctly rehabilitated, no way you have to do surgery treatment because we know that it will not work with physiotherapy. In this case, I think if there is a low shoulder demand, I will keep my preference for a conservative treatment because I see a lot of patients correctly treated with conservative treatment, and you guys, physiotherapists, you do a very good job. But there is a high shoulder demand I like for handball player or rugby player, this kind of player. I think to avoid to waste time, if it is grade 3, we can do a surgery with a correct reconstruction. I would not recommend an arthroscopic technique based on our bad experience. I would recommend a reconstruction of the AC joint ligament with a Waver-Dunn or a Waver-Dunn-like type of surgery. Thank you for your attention. Sorry about the delay. I don't know if we have time to discuss. You know, this is a time for a coffee break. I will do a proposition for you because you need to have the break because there is another workshop. You can discuss during the coffee break. We are here. Feel free to discuss with experts and together, and we are happy to answer to your question. Thank you for your participation. Thank you very much.